Welcome one and all joining us for this last session this week, special sessions for MS Awareness Week. Really lovely to have so many of you joining us today for this special session by Dr. Jonathan White, who will be leading on women's health and living with MS, two of his specialist subjects. For those of you that don't know me, I am Liz Waters. I'm the Community Engagement Programme Manager at Overcoming MS. In a moment, I'll welcome Dr. Johnny to the stage, but before I do that, I just want to run through a little bit of housekeeping with you, which I'm sure that you're all very familiar with by now, but just to keep the session running as smoothly as possible. So just to note that we're recording today, you will receive a link within the week to this, so you can watch it as many times as you like in the future. You'll also notice that we're on a Zoom webinar today, so you don't have an audio or video component, but please don't think that it's not interactive. It is. You can get involved on the Q&A section. So ask your questions. We already have some pre-submitted. We will try and get through as many of those as possible. We are on a shorter session today, but we will do our best. If there are any technical glitches, please try leaving and coming back on the link that you have been sent, and we do recommend that you use a Chrome browser. That seems to work best. We've tried to make it accessible, so we do have subtitles that are available to you. So at the bottom of your screen, you should be able to turn those on. It says closed captioning, so that for anybody that needs that, please do that. And at the end of the session, this is my ask. A pop-up will appear that gives you a short survey. If you have time and if you feel able, I would really appreciate that feedback. We read everything that you send to us, and we're really passionate about making our services as accessible and as appropriate as possible for you. So every bit of feedback helps. So without further ado, I'm really delighted to welcome Dr. Johnny to the stage. Dr. Johnny, are you there?
I think I am.
You are. Hi, how you doing?
That's always a bonus. Yes, I'm very well. Thank you very much for the invitation to come along and talk about two of my most passionate subjects.
Always a pleasure. So MS Awareness Week, I'm sure that you've seen there's lots of things going on online, on socials, and you've probably seen the hashtag MS makes me, and I kind of wondered what your thoughts were on that, if you've had any sort of personal thoughts.
Yeah, I think it's been a brilliant initiative. It's been phenomenal to see that Overcoming MS has partnered with 6 other organisations, and there's been so much activity and interest and buzz about it. And I was thinking about what MS makes me the other day, and I think it's actually, well, it's probably lots of things, but it's 3 main things. So it's made me stronger than ever. It's made me incredibly determined, and it's made me really passionate about things I didn't know I cared about.
So a really, really good week, and I can see that loads of people have been getting involved, you know, our own community. So yeah, this is our final session, so we should set off some glitter cannons at the end and celebrate what we've achieved.
I'm slightly worried that I have to have closed captioning because my accent is so strong, Liz.
Yeah, sorry about that.
Nobody can understand what I'm saying. That's terrible.
So I will leave you to it. We've got quite a short session. I will pop back in about half an hour and we'll have a Q&A. Does that sound all right with you?
Sounds good to me. Thank you very much, Liz.
Fabulous.
Good morning, everybody. Good afternoon, good evening, wherever you are in the world. Thank you so much for joining us for this Women's Health and Living Well with MS webinar. For those of you who don't know me, my name's Johnny White. I'm not a neurologist, and I would always say that at the start of any presentation. But I am a UK registered doctor specialising in obstetrics and gynecology, and I work as a medical advisor for the UK charity Overcoming MS. I myself have lived with relapsing and remitting MS since 2015, and I've spoken and written now fairly widely on the topic of lifestyle modification in MS. So, specifically to today, this is an enormous topic, one that I care very much about for both obvious reasons. And we've done similar presentations in the past, and I've changed this slightly now and updated it, but it's really got me thinking about all of these things. And it's never been more apparent and in the media. Selma Blair, for example, is doing some really enormously important work about representation and disability amongst people living with MS and people in the public eye. But there are things that I really want to cover today specifically. So first of all, why are women more likely to develop MS? Why do they have it more often than men? And then specifically, if you do have MS and you happen to be a female, how does that then impact on fertility, on pregnancy, on breastfeeding if you choose to, on menopause and post-reproductive life? And once we've done that, I hope to answer some of your questions if I can. And if we don't get through them all today, then as usual, we'll keep a list of them, and then I'll write a copy and we'll publish that to all of you who registered. So, as a bit of background, there are approximately 3 million people now living in the world with MS. And overall, the incidence, the chance of developing it is 1 in 1,000, but as we know, it varies considerably from country to country. So as we move north and south of the equator, you're much more likely to develop MS. And where we live in Northern Europe, it's significantly more common than 1 in 1,000, probably around 1 in 5 to 600. It is the most common disabling neurological condition of young adults, and most people are diagnosed in their 20s and 30s. And that's obviously very important for what we're talking about today when discussing things and thinking about things like having families or contraceptive issues, menopausal issues, because most people with MS will go through the menopause whilst living with it. So women's health and MS matters a lot, especially because MS is 3 times more common in females than males. Why is that? It's a really, really important question. And if I'm being totally honest, I don't think we have a definite answer yet. We know that hormones, I mean, if there's a difference between the sexes, then hormones must have something to do with it. And there is some evidence for that, because it's really interesting to see that in juvenile MS, so this is pre-puberty, the incidence is exactly the same. It's 1-to-1 male to female. But as soon as we go through puberty, the gap starts to widen. So by the time we get to adulthood, it's that 3-to-1 ratio that we now see. And that is expanding. It used to be 2-to-1 about 40, 50 years ago. It's now 3-to-1, and we think getting wider. So if you think of the 2 main, in simple terms, hormones, estrogen being the primary female and testosterone being the primary male hormone, is it something to do with them? And well, probably yes, it is. So is testosterone protective? Less men develop MS, they have higher levels of testosterone in the blood. Or is estrogen in some way harmful? Well, possibly, but high estrogen levels, i.e. being pregnant, as we'll see later, are actually protective against MS and relapses and disability progression. So it's complicated, and we don't have the full picture, but I think it's safe to say that hormones are certainly involved. Are genes and genetics involved? Again, probably somewhere. MS is not a truly genetic condition. There are over 200 genes associated with MS, but there's one really interesting gene, S1PR2, which is not the snappiest of titles, that we see in much higher levels in the blood of females. And particularly in those with MS, they have an even higher level of S1PR2 than females in general. And it's important because that gene controls how leaky the blood-brain barrier is. And that's one of the final steps in developing MS. So white blood cells in the bloodstream should not be able to get into your brain tissue. And unfortunately in MS, they do. They get across that final passport control between the blood and the brain. And it seems that that gene controls it. So that's part of this puzzle as well. And finally, does environment play a role? Well, we know that obesity is absolutely related to MS risk and progression. And unfortunately, as a population generally, we are becoming more and more overweight. So within the next decade, it's estimated that over half of us will be overweight or obese. And unfortunately, rates of obesity are increasing more rapidly in females than in males. And that will unfortunately have a consequent rise then in MS rates as well. Vitamin D, we all know, plays a big role in MS. And vitamin D deficiency, which is remarkably common in our population, is unfortunately more common in females, particularly females living in, for example, Middle Eastern countries, where there is less exposure to daylight and more covering up of the body as well. So there are lots of things at play here, and no definite one answer. If we think about fertility and getting pregnant then, MS has no direct effect, either positive or negative, on female fertility. And it's important to say that if you are using a contraceptive method, at the moment, there is no need to change that just by virtue of having MS. There's no known interaction there. So it doesn't directly change your fertility rates, but it can massively impact on sexual function and therefore sexual dysfunction, which of course then will impact on your chances of becoming pregnant if you so wished. So we know that for a variety of reasons, people with MS often have a loss of libido. females with MS often have discomfort and vaginal dryness. There's also an inability to achieve orgasm in some people. Bladder symptoms are remarkably common in MS, as is fatigue, probably the most common of all symptoms of MS, and spasticity can, of course, massively impact on sexual functioning. And unfortunately, depression will affect around 50% of people living with MS. And any one or combination of those things is, of course, going to impact on your sexual relationships and those with your partner. There is, and it's really important to say, and I can say this confidently, that there is no evidence for increased risk of pregnancy loss, be that miscarriage or ectopic pregnancies, because somebody has MS. If somebody has subfertility and MS, and there's no reason to think that you're more or less fertile, as I said, by having MS, but if you do require assisted reproductive techniques like IVF, then there are, in simple terms, two protocols that we use. There's the long and the short protocol. And the long protocol is essentially one that mimics menopause, first of all. And that one, it's not definitive, but in general terms, we try to avoid the long and we prefer the short antagonist protocol because that is more physiological and tends to cause less of the menopausal symptoms and side effects that we think, as I'll discuss later, may impact on MS. But that, of course, is a thing to be discussed with your gynecologist and IVF team specifically. You may have personal circumstances that mean you do require the long protocol, and that's not a disaster in any way, but in general terms, the short is probably the preferred one. So I apologize for this being a busy slide, but it's literally hot off the press, and I think it's really, really important. So it's been published in the Lancet Neurology by Ruth Dobson, who's a UK neurologist and team. And it's a really detailed, thorough, thoughtful piece about family planning issues for those living with MS. And they quite rightly say right at the start that this is an issue that's becoming more and more complex and difficult because the armament or the options in terms of treatment for MS are expanding so rapidly. And with all of those things become different risks, different benefits and interactions and considerations. But the headline thing from this paper, and I think it's really important that we say it, is that most women with MS, if they choose to, can have safe pregnancies and healthy children. And that is not something that people with MS were told, believe it or not. Even in my lifetime, lots of people were told that they shouldn't pursue pregnancy. Oh, how would you cope with the child, with your fatigue, or perhaps a disability that you may accrue in time? Maybe it wouldn't be fair on them. All of these very paternalistic attitudes that were not evidence-based in any way. Also, very reassuringly, early on in the paper, they talk about the importance of folic acid, which for anybody considering pregnancy is vitally important. The standard recommendation is 400 micrograms daily in the preconception period, or if you have risk factors such as obesity or epilepsy, then you would need the higher dose, the 5 milligram dose. Also, as friends of Overcoming MS will be glad to hear, vitamin D is front and center. And the authors recommend doses of up to 4,000 units a day. I'm really pleased to see that as a gynecologist because so often we're told 400 units, don't take more than 400 units. That is, in my opinion, very outdated. We know that vitamin D deficiency affects your risk of miscarriage. We know that high levels of vitamin D are protective for many things in pregnancy. So it's really important, and I'm really glad to see that they do recommend those doses. It's also important to say that doses higher than 4,000 units in pregnancy are extremely likely to be safe. So I know that the recommendations are higher for Overcoming MS on the protocol, but that's extremely unlikely to do any harm at all. And it's much more important to say that vitamin D deficiency is much more risky to pregnancy than having levels that are in the high and safe levels and normal. MRI, if needed, is absolutely safe in pregnancy. It is not radiation anyway, it's electromagnets. And steroids are safe in pregnancy as well if required for a relapse. Specifically with MRI, they suggest that avoiding contrast is probably a good idea. I would agree with that, although we don't have any direct evidence of any harm to the fetus by using gadolinium contrast. There's a lovely section in this about what changes occur to the immune system in pregnancy. And we know that in autoimmune conditions like MS, and more widely in any of them, rheumatoid arthritis or lupus, eczema, psoriasis, etc., the pregnancy often leads to a relative remission in symptoms, especially in the second trimester. So generally speaking, MS tends to improve symptom-wise during a pregnancy. It very often gets worse, and there's about a 10 to 15% chance of relapse postpartum, but there are things you can do to reduce that. There are no specific obstetric or neonatal concerns. just because you have MS. So it's not considered to be a high-risk pregnancy just because you have MS. They do mention delivery concerns with regards to mobility. Can they abduct the hips to put them back into stirrups, for example, if those are needed? Will fatigue play an issue in labour and delivery? But there's no reason to say you can't have an epidural. There's no reason to say you need to have a cesarean section, for example, and there's no direct impact on the baby. And it's also really vital to say that whichever method of delivery is involved does not impact the risk of relapse then after baby is born. There is no long-term negative effect on disability progression by having a pregnancy or having a child. And in fact, medium and long-term data would show that it's probably protective, and that would make sense. You've got that high estrogenic state for 9 months. You have the immune system being turned down as it would have to be so it doesn't attack the fetus, and that in turn offers stability and hopefully improvement in your MS. But there are big issues here. It's fairly obvious to say that it's difficult to trial drugs on unborn children. It's obviously unethical to expose a fetus to an untested drug. So all of these data, this information that we have about any drug, not just MS drugs, comes from long-term experience, people that have been either intentionally or accidentally exposed to a drug over time. So because there is a lack of data, because neurologists are not obstetricians, which is fairly obvious, and they're maybe not familiar and comfortable with prescribing in pregnancy, they will often stop DMDs. And in fact, they'll often do it in a fairly arbitrary and blanket way. So, and I suppose allied to that, women are very often told that they need to forgo breastfeeding. So don't breastfeed, we need to get you back on your DMD as soon as possible. It's not as simple as that. I'm going to show you some data later on. It is so important to say that one of the most important things you can do for your child in terms of reducing their risk of MS in the future is if you choose to and can, is exclusive breastfeeding. If you were to exclusively breastfeed for 4 months, it will reduce their risk of MS by up to 50%. It is so important. So it's not as simple as saying you can't breastfeed. For example, what's to stop you breastfeeding for a few months while taking one of the medications that is lower risk or not using any medication, for example, to get a store of milk into a freezer because you can express and pump more than the baby needs, and then using that when you do go back onto your DMTs, for example. There's so many ways around this, and it just shouldn't be a you must not breastfeed. That's such an oversimplification, and it's really very outdated now. It's about finding a balance, though. This is all about risk and benefit, and I'm not going to list everything on this slide, but it's worth considering this. The risks of continuing treatment are primarily to the baby. That's obvious. The side effects and potential exposure to the medication. The risks of stopping the treatment then are potentially to the mum. Rebound disease activity, for example, stopping fingolimod, Gilenya. There is a significant risk of increase then in MS activity. Will there be an increase in long-term disability by virtue of stopping your treatment? Well, pregnancy is protective. That in itself is a risk-benefit thing. But these are things to consider. What are the benefits of continuing it? Well, the benefits of continuing treatment are primarily to the mum, but then also indirectly to the baby by the mum staying well. And the benefits of stopping treatment, well, that's purely for the baby. So these are the things to weigh up and to consider. And really helpfully, the Association of British Neurologists in 2019 developed some guidance and some really, really clear infographics, the two of which I'm going to show you now, around this whole issue. So some of them we've talked about, the pre-pregnancy counselling, all of these things we've touched on. Obstetric management, there are no specific issues that you need to consider there, but just other than epidurals, diazepam, if you really struggle with spasticity, which can help in labour. But it doesn't mean you need to change things in your pregnancy just because you have MS. I think that these are all really sensible suggestions in here, and I hope that they are becoming more and more widely adopted. So the second picture that we're seeing now is about the specific DMDs. Now, there have been a couple added on since then, but specifically, if you look to the left of the screen as I'm looking at, the first-line injectables, which are the interferons and Copaxone, are now considered to be safe and licensed in pregnancy, but that's taken 25 years. So it gives you an idea of how long this process can take. It doesn't happen overnight. They are safe in pregnancy and breastfeeding. That's not to say that the others are not safe. Some of them may be, but we don't know yet. On the far side, you have things like Lemtrada or alemtuzumab, cladribine and ocrelizumab, which we know you should avoid pregnancy for a period of time. They may need washout and breastfeeding is contraindicated. But then you have things in the middle where it's slightly less clear. But nonetheless, I think that is quite helpful, and there are some specific piece of information on each of the medications there. But you could argue that the risks are overstated. So really helpfully, the AAN Congress is on at the minute in America, the Association of American Neurologists, and some German researchers presented data just a couple of days ago on a huge case series of 3,363 pregnancies, over 2,500 of which were exposed to a DMD in pregnancy. So this is really useful for us. And what they found was that the DMDs, as a general rule, did not increase pregnancy complications like miscarriage or small babies or early babies or stillbirth rates. But Gilenya fingolimod, which we've known has a potential for teratogenicity or causing malformations, does have that increased risk, and there is an association. So that is one not to become pregnant on, absolutely, definitely. As is Aubagio or teriflunomide. Traditionally, it was always said you had to have a significant washout period. That doesn't seem to be the case in this data series and data set, but fingolimod absolutely did. And that's really useful. That's real world data rather than stuff in a lab. There is a suggestion that taking high-dose steroids for a relapse in pregnancy, as well as fingolimod exposure, and continuing with mainly natalizumab, NTZ, or Tisabri, were associated with reduced birth rates. But that data wasn't significant, but there is a trend to be aware of. But generally speaking, this is really reassuring, and perhaps will, I hope, lead to more people continuing on with their DMDs if they choose to be on it during pregnancy, in collaboration between the neurologist and their obstetricians. So moving on to MS and the menopause. And I think it's safe to say that issues around menopause and post-reproductive women's health have never been more in vogue. This is something I hear about on a day and daily basis. I would say that I'm not a specialist in HRT and menopause. I feel like the more I learn about it, the more complicated it feels, but I've tried to simplify it as much as I can for you, and I hope to signpost you to some really useful resources on it. So the average age of menopause is 51. And it's defined as the absence of periods for more than 12 months. So most people think its definition is around things like hot flushes and night sweats and those sorts of things. But actually, medically speaking, it's an absence of menstrual periods. There are, of course, known side effects of that lack of estrogen that comes from the menopause, such as hot flushes and night sweats and changes in our sleep or mood or cognition, bladder function, all these things. Those symptoms, if they are present, can last for generally around 4 years, between 2 and 4 years, but in 10% of people, they will last for 10 years or more. And that has an enormous effect on quality of life, and an even more enormous effect, potentially, if you also live with MS. And there's a significant crossover between MS symptoms and menopausal symptoms. And I've listed a few of them there. So changes in sleep. We know that sleep disturbance is very common in MS, it's very common in menopause, and it directly impacts on your MS symptoms. Mood changes, anxiety and depression are really common and much more prevalent after the menopause, also very common in MS. Cognition, well, we all know about brain fog in MS, we all know about brain fog in menopause, and the two are certainly interlinked. And bladder function, as I mentioned earlier, is a huge issue. Up to 70% of people with MS will have bladder dysfunction. And it's also an enormous issue in the postmenopausal population. But how does menopause link with MS? Believe it or not, we don't really know the answer. There's been conflicting evidence for a long time about this. It used to be felt that the postmenopausal period often led to a worsening of MS and increasing in disability, but there's been a bit of conflicting evidence and uncertainty as to why that happens. Is it due to the lower levels of estrogen, or is it something in the immune system itself? There's a phenomenon known as inflammaging. As we get older, we get a more pro-inflammatory, I suppose, aspect to our immune system. And the two, again, are probably linked. So there's some really helpful information on this. There was a paper published last year, a really high-level review on the effects of menopause on women in MS. really, really well considered, very thorough, very thoughtful, and goes through a lot of these issues in real depth. I would thoroughly recommend Louise Newson's book. Louise is a menopause specialist, and I know many of my colleagues working in HRT and menopause recommend this to their patients. It's very well laid out and very easy to read. I'm a big fan of Dr. Rangan Chatterjee's Feel Better, Live More podcast, and in March there was a really, really good episode on the role of fasting, which I know many people in the OMS community are interested in, and how that affects female hormones. And that is a really, really interesting and insightful conversation that he had with Dr. Mindy Peltz. And I would recommend it to you if you want to know more. So we've touched on menopause. Menopause always leads to HRT. I almost duck and cover when I say HRT because it is just, or has traditionally been, such a minefield of rumor and misconception for so many people. It is extremely effective at treating what we call the vasomotor symptoms, the night sweats, the hot flushes, all of those sorts of things, the mood disturbance, and also the genitourinary symptoms, for example, urgency of urination, urgent continence, vaginal dryness, these sorts of things. I suppose the big headline here is that HRT is much safer than we thought it was previously, especially with more modern preparations of gels and patches. Yes, there may be a small increased risk of breast and ovarian cancers and of blood clots, but that's been probably overstated in the past. And actually that risk is negligible if you're on the preparations which are patches and gels. If you're on estrogen-only HRT, for example, if you don't have a uterus, you do not need progesterone, and then your risks of the cancers are actually no higher than general population. And also, even if they are slightly raised, and you can see the figure there on the right from Cancer Research UK about this, even if they are slightly raised, those risks are much higher in females who drink excessive amounts of alcohol or who are very overweight. So it's important to put that into perspective. Is it beneficial in MS? Well, I was actually talking to a menopause specialist last night at a dinner, and her thing, she can't believe the amount of GPs that refuse to prescribe people HRT just because of MS. And she would be the first to admit that we need more evidence, but her view was MS can negatively impact on your quality of life in a huge way. Why would you make it worse by denying them HRT? And there is also no evidence specifically that people, even if they have reduced mobility, can't have HRT because of this risk of blood clots. They may need to think carefully about the type that they use, but it doesn't mean that they can't have it just because they have MS. And I think that's important, that we're not denying people just arbitrarily things that can really, really positively impact on their quality of life. There are other options other than HRT if you choose not to use them. For example, some of the antidepressants are quite good at treating some of the vasomotor symptoms. Clonidine is very good at that and is non-hormonal. And topical estrogens, so vaginal creams or pessaries that can be used to treat vaginal dryness, but don't impact then significantly on your blood levels of those hormones. There are also natural forms of HRT, for example, soy, black cohosh, red clover, evening primrose oil. There probably is a limited evidence base for their effectiveness. Some are probably better than others, but generally speaking are very unlikely to do harm. So it's a big topic, and one that I know we're going to revisit in the summertime. I'm working on a project at the minute to hopefully do an interview with Dr. Siobhan Kirk, who I spoke with last night, about this very topic, and we will get back to you on that. So if you're interested, please keep an eye on our channels. So that's all I need to tell you, and I'm just about in time. So I would be really happy if I can to answer your questions. If I can't answer your questions, which is always a possibility, then I will of course do some research and I will get back to you. So over to you, Liz.
Hi, Johnny. Thank you so much. That was incredibly comprehensive and such a lot of information in there. And we'll come to, there's a lot of questions that I don't think we'll be able to completely get through. Sure. But I'm just really struck, you know, talking about all of these things. And obviously you're talking about two very separate health teams that are involved in women's healthcare, you know, women living with MS. And that's quite a lot for women to have to advocate for themselves, you know, when obviously two teams probably don't speak to each other all that much.
Absolutely.
What kind of advice, and I know this is probably a whole separate webinar, you know, really, but what sort of simple advice would you give people when they're feeling overwhelmed with having these two teams?
So it is, I think you're absolutely right. It's so difficult when you have two specialties that don't talk to each other, because very few medical specialties do. We all live in silos, and they have a profound misunderstanding of what each other does. So generally, and pregnancy specifically seems to be, people think of it almost like a bomb going off, and they're so reluctant to treat things and use things. And you're right, people are stuck in the middle, and they are very, very overwhelmed and powerless very often. So I think, don't be, first of all, don't, and our community knows this better than anybody, don't be afraid to take agency, to be that voice, the captain of your own health ship, to stand up and say, I'm sorry. For example, if you're postmenopausal, you're really struggling with these things, do some research, show them the evidence, show your GP and say there's absolutely no reason. I was at a webinar the other day, and this idiot from Northern Ireland was saying that there's no reason why I can't have HRT just because I have MS. Your GP will learn something from that, which may then in turn benefit other people living with MS who need HRT. So I think you have to take the bull by the horns, unfortunately, is the first thing to say. And I think there's no harm in saying, please, could you ask for an opinion from somebody who might know more about this? I don't think, nobody should have professional pride in this and say, no, I'm the expert. Those days are gone. Patients are experts, and they need to be empowered to make these choices that are for them.
That's really, really helpful. Thank you. So let's jump into some of the questions. So somebody has said here, I have secondary primary progressive MS, and I'm 5 years into menopause. I do not take DMTs. I would like to know, is it a good time to start taking calcium supplements? And if so, what is the recommended strength or type of calcium to take? And how will I know when menopause is over? Is this checked through blood tests alone?
So no, we don't use blood tests to diagnose or to monitor. Menopause is not particularly effective. So it's, sorry, excuse me, I've got a bit of a frog in my throat here. It's no, it's based purely on clinical features. So it's the things that we talked about in terms of the night sweats and the hot flushes, etc. On average, they last about 4 years. There's no definitive way to know that they're over, other than monitoring your symptoms, I suppose. With regards to calcium, you do need to be careful about taking high levels of calcium on their own. Generally speaking, we don't advise that because it can impact cardiovascular risk. If you're concerned about osteoporosis and bone health, which is definitely an issue postmenopausally, then that's something to discuss with your GP. If you have risk factors, they may want to order certain scans to examine the bone density. But if you're following overcoming MS and you're taking high levels of vitamin D, that will naturally be protective to your bones as well. So I wouldn't advise that people just start calcium just because they're postmenopausal. I'm happy to be corrected on that, but I don't think that's necessarily the right course to take.
Great, thank you. So somebody has said, thanks so much for a great session, so useful and a little emotional. Do you know generally how long Ocrevus, and excuse my pronunciation on the second one, is it ocrelizumab? Has been around? The neurology team I go to in Ireland have advised that we can try for a baby 6 months post-treatment and maybe even 3, based on recent guidance. Is that likely newer guidance than referred to here?
Yes, so it may be, and there will be anecdote. This is a really good point. There's often anecdotal evidence where neurologists and obstetricians have experience with particular things and they're happier to use it. I would always bow to their professional opinion on that one. If if they do have experience, do go with that. I think the ocrelizumab has been around for a long time in another name as rituximab or Rituxan. So we know it's actually one of the better ones in the sense that we have probably more data over a longer period of time to say that it is safe. And I think that 3 to 6 months does sound to me to be the right time frame from the data that I've seen as well. So yeah, absolutely, that sounds perfectly sensible to me.
Great, thank you. Next question. I'm 47 years old and I've had MS since I was 28. When I had my period as normal, my MS symptoms would reduce significantly. However, I went into early menopause at 38 as a result of chemotherapy-based stem cell transplant. I no longer get a reprieve from symptoms. What can I do?
Well, there's 3 little letters there, and I think it's HRT. I think if your quality of life is being significantly impacted by menopausal symptoms, then the first step is to go to your general practitioner, your family health doctor, and to discuss this as an option to you. I think it's really, really important. And in fact, if you've had early menopause, then you're losing a lot of the beneficial effects of estrogen, of the female hormone circulating. And for cardiovascular risk, for your bone health, there are lots of reasons why you should consider HRT. And we would often advise actually anybody who has premature menopause that they do have HRT till at least the age of 50, which is the time when they would naturally go through that process anyway. So I think that's the first protocol there. Yeah,
okay, thank you. I'm hoping to breastfeed exclusively, due in June. congratulations, but want to get formula in case I cannot for any reason. Is it recommended to raise a child dairy-free from birth? Is there a recommended dairy-free formula?
Yeah, so I was actually answering a question on this last week. So in an ideal utopian overcoming MS world, we would exclusively breastfeed for 6 months and then introduce a dairy-free formula. Now, I can't quote you the paper that shows that that's vitally important or that it isn't there, but from the principles that we're advocating, it makes absolute sense to me. So I thoroughly commend if you can, and please don't be too hard on yourself if you can't. Not everybody can breastfeed, and that's really important to say for a whole variety of reasons. If you try and you can't, it is not the end of the world. But if you're choosing to be dairy-free for you and your children, then there are usually soy-based dairy-free formulas that are available. Now, they do unfortunately tend to be slightly more expensive than the dairy equivalent, but they are fairly widely available now. Yeah.
Fabulous. Thank you. Would you advise blood tests to monitor hormone levels to see if hormonal contraception or HIT would help manage MS symptoms, as I notice a worsening of my symptoms before my period?
No, I wouldn't, because the hormone levels in female bloodstream varies enormously throughout the month, and unless you're getting them at exactly the right day and you know the length of somebody's cycle, they're very, very difficult to interpret. And the nice guidance in the UK would be that we don't use blood tests to diagnose or monitor menopause. So I would actually base it much more on your clinical symptoms than any blood test.
All right. Okay. Somebody has written, what drugs do you recommend for smoking cessation? She's putting brackets. I need to quit, but I cannot do it alone.
Fantastic. And it's really important I have this conversation day and daily in the antenatal clinic. And the first thing to say is that nicotine is one of the most addictive substances known to humankind. It hits all the pleasure centers in your brain within seconds, and it's more addictive gram for gram than heroin. So it's not easy to give up. We know that your chances of giving up are massively increased if you do it in a group situation and you have some help. So that's the first thing to say. Second of all, as a way of stopping, believe it or not, vaping is considered actually much, much safer than cigarettes. It's not 100% safe, but it's much safer than cigarettes. I don't have a specific one that I would recommend from an overcoming MS or MS perspective. I know that Champix has been available, is effective, but there are concerns with regards to mental health if that's in the background for you. But if you go into your local pharmacy and say, I need to stop smoking, I have MS, it's massively important. They will hopefully fill a duffel bag for you full of gums and pens and pencils and patches. And I wish you every success. It's not easy, but stay the course.
No, it's not easy. And I did not know that fact about it being more addictive than heroin. So there's a takeaway for me.
Apparently so. I've never tried it. But yeah. Okay,
so how to avoid developing osteoporosis while on the Overcoming MS program, given we can't consume dairy products?
So that's really, really important. That's another massive misconception. This idea that you need to be taking dairy to protect your bones has been put around by the dairy industry for a long time with very little evidence. And I would commend a paper to you in I think it was the New England Journal of Medicine or the Lancet last year called Milk and Health, which essentially shows that you absolutely do not need to consume dairy to protect your bones. And in fact, there are trends to say that osteoporosis and fracture rates are higher in dairy than non-dairy consumers. All non-dairy alternatives, i.e. oat and soy and all the rest of them, are all fortified with calcium, 120 milligrams per litre, the same as dairy. So you're not going to become calcium deficient because you're not taking dairy. That's the first thing to say. Second of all, you're on to a winner on the Overcoming MS program because you're taking high-dose vitamin D. And vitamin D's primary function is to absorb as much calcium as it can from your gut and get it into your bones. So I'm not aware of any data that shows that people who are living as a plant-based diet essentially have higher rates of osteoporosis. In fact, the opposite may be the truth.
Yeah, and you did actually share with me as part of Pathways a document on dairy and impact of health.
And that's the one I'm referring to, actually.
Yeah, and if anybody who's on the webinar is interested in finding out more, I'm more than happy to send that article out to people.
And that's very interesting. That's about not specifically MS, but just human health and dairy more generally. And I think it's a really interesting piece.
Yeah, fabulous. I was diagnosed with MS 3 months back. I just wanted to know, are there any measures that I can take to help preserve or regain my sexual health, as I've got mild numbness of my pubic area?
Yeah, so it's very common. It's very distressing. I think it's probably important to say that this particular person is very, very early into their diagnosis, and all of this is bound to feel massively overwhelming. Very often those symptoms will resolve, that's the first thing, on their own, and you don't need to do anything with them other than be patient and kind to yourself in letting them do that. If intercourse is uncomfortable, then the first thing that we would suggest probably is some form of vaginal lubrication, Replens or any of the normal lubricants that you can buy over the counter. But I think it's important to discuss it with your partner and to let them know how you're feeling. Not to create a barrier that's going to in itself create more issues. Just, sit them down and explain that this, and I'm sure they're aware that this is a difficult thing for you to be going through. And I would be very optimistic that I hope that you start to follow the Overcome MS program, which in the long term is going to be so protective for your MS and general health, and that these symptoms will, I hope, get better just on their own.
Great advice, Johnny. Thank you. Is developing MS at the time of menopause a common occurrence, and is there any reason for this?
Yeah, so the majority of women, and everybody, will develop MS sort of between 20 and 45, but there are people who develop it much younger than that in juvenile MS, and also people who develop it in their 50s, 60s, and 70s. It's a really good question. Does menopause increase the risk of MS? I don't know the answer for definite. But men are more likely to get primary progressive forms of MS. I think men are slightly more likely to develop it later on as well. So I'm not sure that they have a direct correlation. But we do know that, of course, being menopausal will often make MS symptoms worse. So I don't know the answer to that one. To be honest, I'm not sure that we generally know.
Okay, thank you. I've got quite a long question, but I think it's a really important one. So I have 8-year-old twins conceived via IVF. I was only diagnosed with MS 6 months ago and have been following the Overcoming MS plan for 2 months. I'm actually in hospital having my Tysabri infusion whilst listening to this.
Fantastic.
I combination fed my boys for 9 weeks, mixture of breast and formula. Is there a test available in the UK that I can get for my children to test for MS at this age? I'm very worried now, as they have until now consumed a lot of dairy, and I feel guilty.
No. That's such an important question. I'm really sorry about my throat. Please leave that behind you. It doesn't serve you in any way. You will have done more for your twins by now adopting these principles than anybody else living with MS who happens to have children. The absolute risk of your children developing MS is actually still very low. It's in the single-digit percentage number. Yes, it's higher than the general population, but it's probably 1 to 2%. It's not a done deal. They're not definitely going to develop MS. To answer your question, there is no test. There's no one test that you would do on your children to see if they have the gene for MS or are going to develop it. But the most important thing going forward is probably to minimize their dairy intake. My 2 children will consume some dairy because we don't want them to be, anaphylactically allergic to it later in life if they accidentally consume it, at which point they can make their own choices. So that's okay. I would minimize it though. Make sure they have enough vitamin D. So we recommend 1,000 units per 10 kilos of weight, up until the age of around probably 5 or 6, when it can just be the standard 5,000 units a day recommendation. If you can, get lots of flax oil into their mashed potatoes and things as they get a little bit older. Try and do that. Encourage them to manage their stress and to talk about these things, to, my goodness, meditate as a family perhaps. And please don't let them smoke. That seems to be the biggest single risk factor for developing MS in our offspring. That would massively increase their risk. But if you do all of those things, or any of those things, you have hugely protected your twins from their risk of developing MS. And you're doing it right now by even asking questions about it. So please don't be hard on yourself.
Wonderful answer. Thank you, Johnny. Last one, I think that we've got time for. We've whizzed through. I don't think we've managed to cover all of them, but just a reminder that Johnny said that we can answer questions, outside of the webinar. Just send them over to us and we'll make sure that they get answered. So somebody has put, I've steadily put on weight in the last few years. Maybe menopause is a factor. having trouble losing extra kilos, and concerned that the weight loss shakes recommended by the endocrinologist contain milk protein, even though they're very low calorie diet products, so all the fats should have been removed from the milk. Does this mean that those diet shakes can fit in with the OMS diet?
So simple terms, no, if they have milk protein in them or milk products. You also don't need to use them to achieve that. With regards to weight gain and menopause, we do know, unfortunately, as we age, we naturally, all of us will put on weight, probably in the region of around 1 kilo per decade, I think is the standard quotation. There's obviously lots of factors why somebody may lose or gain weight, and also on the OMS program. But one of the things that I would probably advocate, and there's a lot of interest in this in MS, there's a lot of interest in this menopause and women's health generally, is to consider something like fasting as an adjunct to weight loss. So, for example, if you were to engage in, there are lots and lots of different varieties. I'm not advocating one over another, but if you look at some of the information with regards to fasting protocols, for example, the 16-8 or 12-12 or a 5-2 diet, for example, like the Prolon, fasting mimicking diet, all of these things, there's really, really nice data coming through about its benefits in terms of weight control and weight management, weight loss. And you don't need to be taking low calorie shakes with preservatives and dairy and all of those things to achieve that. There are lots of other ways of doing that, and I personally wouldn't want to go down that route myself as somebody following the Overcome AS program. But there's so many options, that perhaps we can delve into another time with regards to that. And I know that Sam Josephs, our resident nutritionist, would have lots to say on that particular subject and know much more about it than I would. But hopefully we can answer that question in more detail.
Johnny, thank you.
Thank you very much.
That was a fabulous session. Thank you so much for running it, for giving such great advice and giving so much, helpful, useful, empowering, knowledge and information to people.
Pleasure.
Thank you very much. Thank you as well to everybody joining us today and for taking part in all the events that we've run this week for MS Awareness Week. Thank you to our digital team for doing that too. Just a reminder that you can go on our events page, and we've got lots more events coming up in the next few months to get engaged with. So please do have a look and sign up. Just thank you again and enjoy the rest of your, excuse me, it's obviously catching Johnny. Enjoy the rest of your days and thank you so much once again.
Thank you very much.